right, it is after 6 o'clock, so we are going to get started now. I would like to welcome everyone and I hope you're all doing well and staying safe. Thank you for tuning in tonight to our webinar on Colorectal Cancer Awareness Month. This is in recognition of March being Colon Cancer Awareness Month, so we thank you for joining us. Before we get started, very quickly, please take note of the Q&A box on the bottom right-hand side of your screen. If you have any questions for the presenters, we will take them at the very end of the webinar. And with that being said, I am going to turn the program over to our first speaker tonight, Dr. Sophie Balzora.
Thank you so much for that introduction. My name is Dr. Sophie Balzora. I am a clinical associate professor of medicine at the NYU Grossman School of Medicine, and I'm a gastroenterologist at NYU Langone Health. So as it's been said, March is Colorectal Cancer Awareness Month, so I'm so excited and actually grateful to be able to speak to you today about the importance of screening, prevention, and bringing awareness to this highly preventable disease. So first I want to start out with the basics. Right? What are the colon and rectum, and what is colorectal cancer? So if you look at the slide and look at this little arrow, this is the colon, which is synonymous with the large intestine, right, or the lower intestine. And when we talk about the rectum, we're talking about this last area of the large intestine here, right before the anus. So when we talk about colorectal cancers, we're talking about any cancer that happens along this large intestine or this kind of sideways shaped C organ, okay? So to break up this talk, I want to go through some very common myths and misconceptions about colorectal cancer. I want to tackle the myths and misconceptions about the disease, about screening and prevention, and about treatment. First, some myths and misconceptions about the disease. I think someone mentioned that the slides aren't advancing. I don't know if anybody else is seeing something different. So first, I'll start with a true or false question. Colorectal cancer affects men much more commonly than women. Is that true or false? That's actually false. And to be honest, we don't really need the slides. It's even better just to have a conversation. So if they're not advancing, it's really no big deal. We can move on because ultimately it's going to be a conversation between you and your doctor, and just think about it that way. But what's important to remember is that everyone is at risk for developing colorectal cancer. All genders are at equal risk for developing the disease. The lifetime risk of colorectal cancer is about 1 in 20, so about 5% over a lifetime. And what's so important to remember, and what is a month dedicated to this disease, is that colorectal cancer is the third most common cancer among men and women, and actually the second deadliest. So the fact that it's preventable, really brings us pause, given the fact that it's actually so common. Another true or false question to think about. Colorectal cancer rates and risk of death from the disease vary depending on race and ethnicity. Is this true or false? It's actually true. Colorectal cancer occurs across all races and ethnicities, but at different rates. Black and Native American or Alaska Native populations have the highest rates of colorectal cancer. Black people are actually 40% more likely to die from colorectal cancer compared to white people. And Hispanic or Latino populations have the lowest screening rates compared to other races and ethnicities. Another true or false question. Colorectal cancer usually causes symptoms, especially in early stages. That's false. During the early stages, most people with colorectal cancer have no symptoms at all. But it's important to know the signs and symptoms of colorectal cancer so we can act expeditiously. Some symptoms you need to watch out for include blood in the stool, diarrhea or constipation that's new to you. So let's say you're usually a 3 times a day person or 3 times a week, and all of a sudden you're having bowel movements only once a week or 3 or 4 times a day. So that sustained change is something that should bring you to the office. Pencil-shaped stools, right? We talk about a change in caliber of stools, right? All of a sudden they're very different shapes that you're not used to. That's something that you should bring up to your doctor. Abdominal pain or cramping, and not just a one-off, but something that is chronic, right? Something that keeps happening and you really just can't explain why it's happening. Again, talk to your doctor about this. Unintended weight loss, or I'll add to that, weight loss that's just much greater than you would ever expect for the kind of effort that you're putting into it, right? weakness and fatigue that you can't explain, or anemia or low blood counts or low iron stores. So each one of these symptoms is something that we should absolutely bring to our doctor's attention because it may warrant further workup like a colonoscopy. Another true or false question for you. Colorectal cancer rates are dropping for people over 50 years old. Thankfully, that's true. But what's also important to recognize is that colorectal cancer rates are actually rising for those under the age of 50. Most colorectal cancers are diagnosed in those over aged 50, but the disease can affect people at any age. People with a family history of colorectal cancer, people with a history of Crohn's disease or ulcerative colitis, which is called inflammatory bowel disease, and those who carry certain genetic mutations are at increased risk of developing colorectal cancer at an earlier age than 50. So if your medical history tells us that you are in this category that puts you at increased risk, or if you're having any of the symptoms that we talked about, blood in the stool, abdominal pain, changing your bowel habits, unintended weight loss, then you should definitely be evaluated for colorectal cancer, regardless of your age. And so there's this phenomenon that we've been seeing over decades. It's called early onset colorectal cancer. And again, those are those that occur before the age of 50. And we're seeing this phenomenon more and more often. And so I think the point of this is that we cannot ignore these symptoms that I've discussed. In the US, approximately 15% of colorectal cancer cases are early onset or under the age of 50. Early onset colorectal cancers are usually found in the lower colon. So remember earlier, I said that the rectum is that last part of the large intestine right before the anus. That's where we oftentimes see these early onset colorectal cancers. And they oftentimes present at advanced stages, right? And so that means early onset colorectal cancer actually usually presents with symptoms. And so that's why it's so important to stress that we cannot ignore those symptoms, and we cannot just ascribe it to something like hemorrhoids or a fissure, though that is a much more common condition. We have to bring it to our doctor's attention so a proper evaluation can be conducted. Because we do need to remember that despite the rising rates of early onset colorectal cancer in this group is still relatively uncommon, as the overwhelming majority of cancers occur above the age of 50. The other crucial point I want to make tonight is to know your family history.
This is Rachel. Just to jump in, there should be a panel on the left. Can you see if you can advance it that way?
Panel on the left, sure. How's that work?
Nope.
Do you see it changing? It's still,
if that doesn't work, can you try manually doing it with right-clicking?
That's what I've been doing.
We still see the cover slide.
Yeah. I mean, as I said before, obviously not perfect, but I think that the slides, are a compliment, but ultimately, it's really the information. But I tried to use the arrow and the panel on the left, and neither seem to be advancing the slides from what you're telling me.
You know what? You want me to try to do it on my end real quick? And if it doesn't work, you can continue.
Okay, sure. I'm on slide 18.
Okay. All right, hang on one second. Everyone, just bear with us for one moment. Okay, 18 you said?
Yep, right there.
Okay.
Knowing your family history.
All right.
I think that seemed to have done the trick.
Okay, just tell me when I need to advance.
Sure. So as I was saying before, knowing your family history is, I think it just went, there we go. No problem. Knowing your family history is so critical, right? We have to have these conversations because they truly can save lives. But as you can see on the slide here, when you have no family history of colorectal cancer or an adenoma, your risk is, of average risk. But then if you have a family history of an adenoma, which is a precancerous benign polyp, right? That's how colorectal cancers start out, as a benign small growth. Then your risk increases. And then think about having a first-degree relative with colorectal cancer. So this means your siblings, parents, or children. The risk goes up still. And then think about that family history where there's a first-degree relative who has a cancer at a young age, under the age of 50. The risk climbs again. And then if you have more than one family member who has colorectal cancer, the risk is highest. So knowing your family history is so crucial. It's so important to have these kinds of conversations because they truly can save lives. Next slide, please. So now to tackle some myths and misconceptions about screening. Next slide, please. True or false? Colorectal cancer screening begins once you have symptoms of the disease. Next slide, please. That's false. You can click on that little picture there. There's a little video. What does it mean to undergo a screening test for colorectal cancer? So I want to stress again that screening absolutely saves lives. Screening tests are those that we do for people who have no symptoms. And there are two categories of testing. There are prevention tests and detection tests for colorectal cancer. And that makes the disease highly preventable for over 90% of people. Next slide, please. So I want you to make colorectal cancer screening an absolute priority. Next slide, please. Most colorectal cancers develop from polyps, or small precancerous growths in the colon, or the large intestine. Preventive screening tests find precancerous polyps so they can be removed before they turn into cancer. Next slide, please. Detection screening tests primarily function to detect early colorectal cancers. Next slide, please. So prevention tests are actually preferred over detection tests because we can actually prevent the cancer from occurring. Next slide, please. So here, a picture tells 1,000 words, and I want to go through what a benign precancerous polyp looks like. And those, again, are called adenomas. So on the left, you see a picture of colonoscopy occurring, and you see that black tube there is the colonoscope, or the camera. And there's a little lasso around a polyp. So we can remove polyps in real time during your colonoscopy. And then on the right, you see an actual picture of a real polyp during the colonoscopy. And this is magnified quite significantly. Most polyps are smaller than your pinky nail. Next slide, please. Another question for you. Preparing for a colonoscopy is difficult and the procedure is embarrassing and painful. True or false? Next slide, please. So that's false. Colonoscopies save lives, and they're not as bad as many may think. The procedure usually takes about 30 minutes to complete, and most patients are sedated for the procedure in order to prevent any possible discomfort. The steps needing to remove stool from the colon, which is commonly called the colon prep, may be the toughest part of the procedure and an inconvenience, but the benefits of the procedure are very clear. Next slide, please. Wow, this prep is so delicious, I think I'll drink another, said no one ever, right? So anybody who's had a colonoscopy knows that the prep is absolutely the worst part, but it's only temporary. And again, the advantages are, limitless. Next slide, please. True or false? Colonoscopy is the only way to screen for colorectal cancer. Next slide, please. That's false. Next slide. There are many recommended screening tests for colorectal cancer. The preferred prevention test is a colonoscopy. We recommend a colonoscopy every 10 years for people who are of average risk. And to review that again, average risk are those people who have no family history of the disease, have no personal history of colon polyps, have no genetic mutations that predispose them to colorectal cancer, and have no history of inflammatory bowel disease. Screening begins at age 45. And I know some people may say, hey, I thought it was at age 50. But recent guidelines tell us that we should actually be screening at age 45 now. And part of the reason for lowering that age is because of these early onset colorectal cancers that we're seeing. And if we're thinking about prevention, we want to catch the polyps that can become more troublesome along the way if they're left in your large intestine. So if you belong to one of these high-risk groups that I listed before, screening should begin even earlier. Next slide, please. And then what's the preferred detection test? It's called a fecal immunochemical test, or a FIT test. FIT testing is recommended yearly for people who are of average risk. It looks for hidden blood in the stool, so blood that you can't see with the naked eye. With a positive test, a colonoscopy is the next step. We think about it as kind of like a two-step process. And I want you also to remember that detection tests are only for people who are of average risk. For people who are of high risk, a colonoscopy is recommended. Next slide, please. So again, the preferred test is a colonoscopy. because it can actually prevent colorectal cancer from occurring. But there are alternatives to colonoscopy and to FIT testing. Alternative prevention tests include something called a flexible sigmoidoscopy, which is basically just a fancy term for an abridged colonoscopy. It uses the same type of camera, but it only looks at about, a third or a half of the large intestine. It's also important to understand if there are polyps that are found during this flexible sigmoidoscopy, a colonoscopy is recommended as the next test. Alternative detection tests include something called a virtual colonoscopy or CT colonography. That's a special type of CAT scan that looks for larger polyps. There's also stool-based DNA testing, which looks for abnormal cells along the colon lining. If polyps are suspected or early cancers, meaning if the test is positive, again, the next step is a colonoscopy. So ultimately, all roads lead to colonoscopy, which is another reason why it's deemed the preferred test. Next slide, please. Another true or false. It is safe to undergo colorectal cancer screening during the COVID-19 pandemic. Next slide, please. And that's true. Next slide. Colorectal cancer does not wait. Experts estimate a greater than 1% increase in colorectal cancer deaths secondary to the pandemic in years to come, as we'll see. There are safeguards in place to help you get screened safely despite the pandemic. Discuss with your doctor which colorectal cancer screening test best fits your needs and your risk. And don't let fear prevent you from getting screened. Next slide, please. True or false? There's nothing I can do to prevent colorectal cancer. It's all just a matter of bad luck. Next slide, please. That's false. Next slide. There are ways to reduce your cancer risk. Of course, there are factors beyond our control that we cannot change, but there are factors that you can change. We can't help getting older. We can't help our genes, right? A family history is something that we can't, we can do nothing about, unfortunately, or a personal history of colorectal cancer or polyps. But things that you can do to help reduce your risk: stop smoking, drink alcohol only in moderation, limit red meat intake, eat leafy greens and fruits, maintain a healthy weight, be active, and of course, get screened. Next slide, please. So some myths and misconceptions about treatment. True or false? There's been a rise in colorectal cancer rates, colorectal cancer survival rates since the 1980s. Next slide. That is true. Next slide. Colorectal cancer survival rates are high when the disease is caught early. 5-year survival rates for colorectal cancer found at earliest stage are 90% plus. When the cancer is spread or metastasized, survival rates diminish. This is why screening for colorectal cancer before the onset of symptoms is so crucial. And screening with colonoscopy lowers colorectal cancer death by over 50%. Next slide, please. So remember, colorectal cancer screening saves lives. Everyone is at risk for colorectal cancer. Colorectal cancer screening begins at age 45 and even earlier in those who are high risk. Know your family history. The best screening test is the one that gets done appropriately. Preventive screening tests like colonoscopy are preferred over detection screening tests. Do not ignore symptoms of the disease, and don't let COVID-19 prevent you from getting screened. Next slide, please. So to learn more about colorectal cancer prevention, screening, and awareness efforts, you can go to the websites listed here. NYU Langone Health has some great resources, the American College of Gastroenterology, as well as the Association of Black Gastroenterologists and Hepatologists at blackandgastro.org. Next slide. So thank you so much for your time and for dealing with our technical difficulties, and I'll pass it on to the next speaker.
Thank you, Dr. Balzora. That was really informative. We appreciate you sharing that information with us tonight.
Sure.
All right. Okay, I am going to pass the presenter rights over to you, Dr. Grieco.
Excellent. Okay. And we can see the screen?
Yep, that looks perfect.
Great. So thank you, Dr. Balzora. That was wonderful. So I'm Michael Grieco. I'm a colorectal surgeon here at NYU, and I'll be giving a talk on the surgical management of colorectal cancer. So to kind of start the talk, why surgery? So I'm going to kind of start briefly with why I'm doing surgery. So back when I was in college, I was pre-med. I was interested in going to medical school. Wasn't exactly sure what I wanted to do. And my mother bugged my father to get a screening colonoscopy at NYU, actually. And so they found an early stage right colon cancer. And he went on to have surgery at NYU. It was uneventful. And he quickly went back to work. And he's been fine ever since. So this is, we're on year 20 at this point of this. So I was a fan. And my first patient as a medical student was a man who was my father's age, and he did not get screening. And he was in the hospital, and his wife was sitting there with him, and she was so teary-eyed because he had extremely advanced disease that was beyond the place of being cured. So it kind of hit home how important screening was and how important surgery can be a role in helping people. So surgery broadly for colon cancer can help prevent colon cancer from progressing if a precancerous lesion is found. It can cure colon cancer, and roughly about half the time it's the only cure needed, and chemotherapy is not necessary. And it can palliate people with colorectal cancer problems. So if they're suffering from their disease, surgery can help them. And this is done in conjunction. And surgery is just one of the many modalities that are used in concert in a team approach. So it's the gastroenterologists that help identify the colon cancer and prevent it, and also to help palliate it with colonic stents. And radiation oncologists and medical oncologists that help with the chemotherapy and radiation that are helpful, and a team of subspecialty nurses and nutritionists that can help patients thrive. So questions that people have when they are told they have colon cancer or are contemplating colon surgery is, will my entire colon need to be removed? And in most cases, it does not have to be removed. And in most cases, patients who have colon surgery will have very similar lives to the lives they had before they had their surgery. People ask, well, don't I need my colon and my rectum to live? And curiously enough, even though problems with your colon and rectum can be life-threatening, they can be, if they're removed, you can safely live a long life without them. And a common question also, will I need a bag? And the answer to that is rarely. So only a very, very small subset of patients will need a permanent bag. A slightly larger amount will need a temporary bag, but the overall majority of patients that have colon cancer will not need an ostomy bag. And the surgery, it depends on the case and what are the medical issues the patient has, what are the previous surgery history and their particular disease process. Typically the case lasts a few hours, sometimes a handful. And people are in the hospital on average for 2 to 5 days, about 80% of the patients, and then 20% of patients stay longer than that. And people understandably ask when to get back to work. And again, this varies on your own medical history and your own surgical problem needs to be addressed. But pretty typically, people can get back to work on a range of about 2 to 6 weeks. So, and some people can even get back to work sooner. Their energy probably level isn't fully back for probably about 4 to 6 weeks. So I want to kind of spend a little time demystifying what can be kind of a scary topic for people and a little confusing. So we're going to start with, where are we operating? What's the organ we're treating? So it's the colon. So the colon is the downstream part of the digestive system. So food gets crushed in the mouth and swallowed into the stomach. The stomach crushes it further, starts breaking it down with enzymes. Throughout the small intestine, more enzymes are added and the calories are absorbed. And then by the time the liquid gets to the colon's job is to absorb water and some salt. And so it then gets stored in the rectum and then comes out of the anus in the bathroom. So when the colon or rectum develops problems that need surgery to remove, we have techniques to remove part of it. So if this is on the left, that's the whole schematic of the digestive tract. And on the right, it's a picture of the incidence or the frequency with where colon cancer happens. So in the beginning part of the colon, it's about a third, in the middle and the middle about 20%, and in the downstream part, it's another 20 to 30%. So the anatomy of the colon is shown here. And this is just to show kind of an abstractly how there's a very clear anatomic planes that are delicately divided and followed. And as one surgeon at NYU likes to say, we kiss the tumor to death. So we really make small, tiny little cuts and very gently and delicately remove the organs and leave other things that are sleeping and resting there in place, so to speak. So depending on the different areas of where the cancer is, there's different ways to reconstruct, and this is true of any different approach. So if people have left colon cancer, and we see the segment in the darker area here on the section A is the segment with the tumor that needs to be removed. And so the remaining ends of the tubes that are remaining, the sigmoid colon and the transverse colon, they can get reconnected in what's called an anastomosis, or a connection between the two tubes. So now when this person on the right eats food, it goes into their stomach, gets processed, and then it goes to the rest of the colon through that new little tunnel, that little door between the upstream colon and the downstream colon, and they go to the bathroom the normal way. Similarly, this is true for most rectal cancers in which the rectum is disconnected from the sigmoid colon and the anus, and then the colon is connected, the sigmoid colon is reconnected back to the anus. So, and this is similarly true for rectal cancer that's of the very rare type that can't be reconnected. And again, this is an increasingly smaller subset of patients. There have been advances both in surgical technique and in the use of chemoradiation and chemotherapy in order to shrink the tumor down to the extent that the anus can be salvaged. But in the very rare instance that the anus can't be salvaged, the patient would have a colostomy bag. But again, this is very, very uncommon. And part of the subspecialty of colorectal surgery is to provide patients management options and techniques that will allow them to preserve their anuses so they can function in continuity in the natural way. There are a small subset of rectal cancers that can be managed without any incisions at all. It's called transanal surgery. And so that with the patient all asleep, a little disc is excised that requires the patient to not even stay in the hospital even one day. So over time, have things changed? And they definitely have. So if you look on the left, the rotary phone that I remember very clearly my grandmother had, and then the 1980s Gordon Gekko phone, and now we have the Apple iPhone watch in which you can get phone calls even without your cell phone being there. So things have progressed tremendously, like over this time period of, let's say, 50 years. And the traditional approach is still very valid for patients that need it, and there definitely are a subset of patients that are very appropriate for. But many and majority of patients are candidates for what's called minimally invasive surgery. So this is an approach, a tremendous amount of research and care and technology and thought has gone into making the impact on the patient smaller and smaller. And this is primarily through smaller incisions or cuts, but this is also through other approaches, which we're going to get into in a little bit. So the three most commonly discussed minimally invasive approach are laparoscopic, robotic, or incisionless transanal surgery. Minimally invasive surgery, instead of having the long traditional incisions, have tiny incisions, and they work with little working ports. And the benefit is that the smaller holes in the abdominal wall lead to decreased pain, decreased length of stay, decreased risk of infection, and a faster return to work, and decreased chance of hernia down the line. So one thing to note about the robot is that technically it's not really a robot. It's a little trade secret. The robot is something that's capable of, the definition means something that's capable of automatically carrying out complex series of movements, especially one that's programmable. And the surgical robot of one type that you see here, which is the most common, it can't operate automatically. The surgeon is moving their hands, and as their fingers pinch, the little tiny instruments pinch right along with it. So it mimics the surgeon. It doesn't actually function independently in any way. A rare subset of rectal cancer patients can be treated with called transanal minimally invasive surgery. This is the incisionless approach I was alluding to, which when the patient's asleep, a little port is placed in their anus, and some surgery is done through that port. And so the small specimen that is removed is taken out. The patients have no incision. They can go home the same day. Now, in addition to the tremendous advances that have occurred in the instrumentation of surgery and the surgical technical approaches, almost a similar amount of thought, care, and dedication has gone into figuring out all the other parts of the package. So this is a schematic in a picture form of an enhanced recovery after surgery pathway. This has been a tremendous area of research in the last decade. So this impacts how do we make the patients comfortable? How do we give them better postoperative pain control? How do we have them better outcomes? How do we get them back and functioning back to normal as soon as possible? And so what we're used to, and this is from everything from even the food before surgery. So it used to be no food after midnight. You couldn't eat anything up in your time of surgery. And if you had surgery in the afternoon, you could have nothing to drink all day long. And research has shown that having clear liquids the morning of surgery up to 2 hours before surgery is very safe. So the hospitals have agreed upon policies that allow that. We now started giving patients non-narcotic pain medications preoperatively so that they have the drugs in their system before they even have the first needle stick of their intravenous line or before they've had their incision. Patients get, there's an advanced ultrasound-guided local anesthetic or numbing that can be given to the abdominal wall to, again, make the patients not even feel the pain before it happens. Medications such as scopolamine patches can be given beforehand to prevent possible nausea. Intraoperatively, multiple modes of non-opioid pain medication, lidocaine and ketapine and ketorolac, all with the goal of decreasing the patient's pain in a way that doesn't use narcotics, which can in addition be, although they're famously habit-forming, can also are known to cause nausea and vomiting, and so we're looking to prevent that. And attention to controlling the patient's sugar and their ventilation and their oxygen levels, all these things to optimize avoiding infection. And increasingly avoiding people having unnecessary tubes and globally having patients avoid undue burdens on the patient so they can recover better. And technical care, their fluid balance postoperatively with medications that are non-narcotic. And although we have narcotics as rescue agents if the patients really need them, we have a whole host of different medications all working in concert together that are non-narcotic to really minimize pain and help people recover. In addition to that, sometimes there are approaches that have drains or tubes that are left in patients, and we really try and minimize and avoid that at all costs. And so the benefit of this is this has shown to have patients with better outcomes from every metric of early leaving the hospital, earlier back to work, less rates of infection. So it really is a tremendous value for patients, all this care that's gone into making things easier for them. And this is something that is done, again, although it's centered around the patient, it's a team that takes care of things. So in addition to the leading edge of it is the gastroenterologist that finds the cancer and their support services around them that helps you get through that experience of having the endoscopy and finding the thing and preventing tremendous amount of problems. It's, as Dr. Balzora said, was invaluable. It's infinitely valuable. The radiologists that help look for other possibilities, other problems that could be arising, the medical oncologist and radiation oncologist that may be needed after or sometimes before in order to optimize patients for particularly rectal cancer for surgery, and the pathologists that help analyze what the gastroenterologists find or what the surgeons resect. And so this is all working in concert with the nurses, the physical therapists, the nutritionists, all in concert to really, all these subspecialists are working towards the goal of having the patient recover well and to flourish. So in summarize, colorectal cancer is a common disease that's both preventable and curable. So the goal is to catch it early, and we don't want to catch it late, which is why Dr. Balzora advocates the screening, which I wholeheartedly recommend. And this is just not, this is money where mouth is. I mean, I had a discussion with my parents about this and encourage them to keep their screening going. And my dad's a big advocate as he's a survivor because of the screening. He's alive here because of the screening. The multimodality team is important for the best outcome. And it's important to seek out teams at high volume centers for the best outcomes at all. Anyway, thank you for your time. And it really was an honor to present here during March Colon Cancer Awareness Month. Thank you.
Can everyone hear me okay? All right, hold on. Bear with me 1 second. Okay. Good evening, everyone. My name is Marissa May. I'm a dietitian at NYU. I work at the Perlmutter Cancer Center. And today I'm going to talk about colorectal cancer awareness and the impact of nutrition, diet, and exercise. So to start, we're first just going to discuss how diet and exercise play a role in prevention. As you've heard tonight, there are many factors that can increase the risk of colorectal cancers. And many of those factors you actually have control over. The American Institute of Cancer Research, or AICR, estimates that 47% of U.S. colorectal cancer cases could be prevented each year through healthy lifestyle changes, and this includes what you eat, what you drink, your weight, and your physical activity. So how can you actually play a role in preventing colorectal cancer? There's strong evidence that shows that you can decrease risk by increasing your physical activity, increasing your intake of whole grains, increasing foods containing fiber, dairy products included, and as well as yogurt, and increasing your calcium as well. Items that can increase risk include eating a lot of processed meats, having an excess amount of alcoholic drinks, body fatness, meaning overweight or high or obese BMI, and increasing your red meat intake. So basically the takeaway is that maintaining a healthy lifestyle, including fiber, foods, mostly plant-based diet, and including regular exercise can help. And we'll take a look at what that exactly means specifically. Okay. So the American Institute of Cancer Research has a blueprint of recommendations. So it's a kind of a step approach to really looking at a whole picture of cancer prevention. So you can follow these, individually, but really following them as a whole has a greater impact. So, and it's really kind of changing your way of life. And not only does it have an impact on cancer prevention, but it also has an impact on other chronic diseases like diabetes and heart disease. So let's take a look specifically at what each of these things mean. So being a healthy weight, what does that mean exactly? Generally, weight is often expressed in terms of BMI or body mass index. So a range of 18.5 to 24.9 is what's considered a healthy weight. 25 to 29.9 is considered overweight. And over that, it would be considered in the obese arena. So, keeping your healthy weight range and avoiding weight gain throughout life is highly encouraged. Being physically active. So what is the recommendations are 30 minutes of physical activity 5 times a week. That can go a long way towards improving your health. Weight resistance training twice weekly. So it improves your health and it also can help preventing weight gain. So that ties into, maintaining a healthy weight as well. So we had talked about fiber, and a lot of times what fiber foods include whole grains, vegetables, fruits, and beans. So including these more in your diet, making your diet mostly plant-based can play a big role in preventing cancer as well as contributing to a healthy life. A good rule of thumb is thinking about covering at least 2/3 of your plate with plant foods. So, these items listed here, and 1/3 of the plate can be filled with animal-based protein foods, and those are things like chicken, fish, and then limited red meat amounts. Limiting consumption of fast foods and other processed foods. These foods are often high in fats, starches, and sugars, and a lot of times when people eat processed foods, they eat a high volume of them, so they eat them in very big portions. So this can have a negative impact on your health as well as lead to weight gain, which we've established is one of the factors in preventing cancer. So limiting processed and red meats. The general recommendation is no more than 3 portions a week. That's a total of 12 to 18 ounces per week. If you think about the palm of your hand, that's about 3 to 4 ounces, so that can kind of give you a good rule of thumb of how to measure it. Thinking of lean meat as more of a side dish, instead of the larger portion of the plate, which many of us are accustomed to. And consider going meatless every now and then. And I'm sure you've heard of Meatless Monday. Making a day with having no kind of animal protein or meat throughout that day, choosing more plant-based proteins like soy or tofu, lentils and beans, grains that contain protein like quinoa are good options to consider on those days. And you can even include some dairy products as well, which are also excellent sources of protein. Limit your consumption of sugar-sweetened drinks, choosing mostly water and unsweetened drinks. Lots of sugars and sugary drinks, sodas rather, or sweetened iced teas and lemonades. A lot of those shakes that you'll find on the shelves, a lot of these are very high in sugar, and this can all contribute to weight gain as well. And you want to try to limit your alcohol consumption. Ideally, it's best not to drink at all. If you do drink, you want to try to, for men, limiting it to 2 drinks a day and 1 drink a day for women. And ideally, you want to get most of your nutritional needs, meaning all the vitamins and minerals, through foods, fruits, vegetables, proteins, whole grains. This is the way to approach the diet rather than relying on supplements or vitamins for cancer prevention. So after a cancer diagnosis, we do also will recommend following these guidelines that we just reviewed for cancer prevention. However, there's a lot of factors that can affect the diet, and sometimes we need to modify it and adapt it based on how the patient is eating, as well as some of the treatments that they're receiving. So we just saw, some of the treatments that patients may experience, and the nutrition needs can change based on that. The goal of nutrition therapy during cancer treatment is mainly to prevent or reduce nutrition deficiencies, achieving or maintaining a healthy weight. We actually don't encourage weight loss during active treatment as a way to prevent recurrence. So, in preserving lean body mass, meaning muscle mass, minimizing nutrition-related side effects and complications, maintaining strength and energy, and protecting immune function by decreasing the risk of infection. This aids in recovery and healing and maximizing the quality of life. So we just saw some of the treatments that patients can go through. This can happen before or after chemo. So surgery, we just went through some of the surgical treatments that patients might have. This will often affect the diet. Oftentimes, patients will transition to a regular diet, but they will usually start out on a modified diet. So we have to take those things into consideration. Chemotherapy can have side effects that might vary with treatment. The radiation, that can also affect it. And sometimes patients will even present with issues even before their diagnosis and treatment. This can include something like an obstruction, pain, or even the cancer itself. And even emotional factors. A lot of times just going through this process can produce a lot of fear and anxiety, and this can affect the appetite and how people eat as well. So, early nutrition intervention is a key role in cancer care. As we've mentioned, working together as a team with the doctors, with the nurses, with nutrition, we provide interventions in nutrition that can be really helpful across the whole care continuum. At the Cancer Center, we meet with the patients to assess their needs. We look at their circumstances. We take into consideration any diet changes that might be needed or what's appropriate for the patient. We look at any conditions that they might have. Do they have diabetes? Do I have to consider that as well? Because we do want to, each patient is an individual, and we take into account all the factors that come into play. It's not just one thing. We look at the whole picture and even just their general lifestyle to make sure that we're recommending a diet that's appropriate for them. As we discussed, a general healthy diet is recommended if it's tolerated. If the patient's feeling good, if they're eating well, we want to encourage a mostly plant-based diet. We want to maintain calories and protein along the way. Oftentimes, calorie needs and protein needs are actually higher than what they would be normally. So are we, I'm looking to see that patients are maintaining their weight, and if we need to adjust their diet, but include higher calorie foods or higher protein foods, this can be helpful throughout the process. And, as I mentioned, dietary adjustments might be needed, sometimes after surgery or for specific issues, we may recommend a low fiber diet to start. For example, if there is colon resection, the patient may start out on a low fiber diet, but over time, they can transition to eating a regular diet. A lot of times that we have to consider side effects of the treatment and the management of that. This can include nausea or appetite changes, constipation or diarrhea. So we have to take those things into account and make recommendations based on those. Small frequent meals can often be helpful with digestion. So what that means is just eating smaller amounts more often throughout the day, thinking every 2 to 3 hours, maybe 5 or 6 meals throughout the day versus the standard 3 meals that many of us are accustomed to eating. Dehydration is a common side effect of cancer treatment. So staying hydrated is going to be really important. This can help with managing the treatment, making side effects less severe, lowering chances of missing treatments later on. And physical activity, we encourage that during treatment as well. It helps with managing fatigue, it helps build your appetite, and it can help maintain muscle mass as well. So as long as you're able to be active, and of course, if you're medically cleared, if there's any surgery that's taken into consideration, we encourage activity, as we discussed, 30 minutes a day as well. So maintaining calories, proteins, and fluid. During treatment, as I mentioned, keeping nutrition up is going to be important. Getting enough calories, proteins, and fluid is important to help maintaining weight, muscle mass, and can also help decrease fatigue. So, I mentioned eating the 5 or 6 small meals a day instead of 3 large meals, which could be helpful. Eating smaller portions at one time can also be helpful if there's any sort of appetite changes. A lot of times if you have appetite changes, having a big plate of food can be very off-putting. So having the smaller amounts of food spread out throughout the day may just be a more manageable way to approach it. Sometimes people may feel full very quickly from small amounts of food. So eating the small frequent meals, kind of helps spread things out throughout the day as well. some ideas for snacks. I always will push things that are generally higher in calories, especially if there are appetite changes. So things like peanut butter, cheese, yogurts, and I will usually recommend a full fat yogurt, egg salads or chicken salads, scrambled eggs, avocados I love as well. Avocados are high in fiber, but they're very high in calories. So as long as people are able to tolerate them, it's one of my favorite things to recommend. Oops, sorry. Okay, so include a protein at each meal and snack. As we mentioned, maintaining muscle mass is going to be important. Protein's also important to help, excuse me, with immunity and keeping your strength up. So high protein foods include things like meats and fishes and chicken. As we said, less of the red meat, more of the lean proteins like the chicken and fish. Plant proteins, if they're tolerated, beans, lentils. Tofu is an excellent plant-based option, very high in protein, or even soy milk, is a replacement for dairy milk if it's not tolerated. I mentioned yogurts and how dairy can actually decrease the risk of colorectal cancer, so yogurts are a good option. Cheese, eggs, seeds, nuts, and nut butter. And as I take a sip of water, stay hydrated. Aiming for 8 to 10 glasses of 8-ounce glasses a day of fluid. I always say fluid because it doesn't necessarily have to be only water. Sometimes it's just very difficult to drink that much in a day. Sometimes the taste is just not appealing. So, consider other options. Maybe it's tea, an herbal tea or a flavored tea, seltzer, Gatorade, Pedialyte, broth, even chicken broth or vegetable broth are great options for fluids as well. And if you want to add a little bit of flavor to something like water, you can add a little bit of juice to, or dilute the juice, or even some cut up fresh fruit, or herbs and things like mint and parsley, or can be added to water to change the flavor if the flavor is not appealing. And then what happens after treatment? So, we finish treatment and, what are you thinking, what am I going to do next? So we will defer to the AICR guidelines that we just talked about. The American Cancer Society also has guidelines that they recommend that are along similar lines. So, as long as you're able to tolerate a healthy diet, we're going to encourage that. At this time, I had mentioned earlier that we don't encourage weight loss during treatment, but we've talked about how maintaining a weight can be beneficial, and this also applies post-treatment. So at this time, once treatment is finished, if you are in an overweight or obese BMI range, we would recommend trying to lose weight and maintaining a healthy weight. And you can do this by setting goals that can help promote overall health, quality of life, longevity. We talk a lot about what to do. Sometimes setting goals can help with the actual of how to do it. So making healthy lifestyle changes, we just reviewed, what we need to do. So as I mentioned, a lot of times the how can be really challenging. So we'll talk a little bit about we will recap again about what we need to do and then actually figure out, how do I incorporate these changes into my life? So eating well before and after treatment. It's one of the ways to accomplish that, as we've talked about, is, I'll say it again, focusing on a plant-based foods diet to reduce cancer risk and also cancer recurrence. So this means increasing your fiber intake. The recommendation is 25 to 30 grams at least, not maximum, but at least a day from food. Again, these include whole grains, vegetables, fruits, nuts, beans, legumes. And an easy way to kind of apply that is maybe looking at your plate. Instead of actually sitting there counting and calculating, how many grams of fiber am I eating? Every time you have a meal, use this model here that is from the AICR as well to kind of model what your plate should look like. So making 2/3 of your plate or more fruits and vegetables, whole grains, and beans. So this can help you with managing your portions so that you could also use this for, achieving weight loss if that's what needs to happen, and just maintaining a healthy weight as well as part of a balanced diet. And then in moderation, you're going to do the animal-based foods. So these are the proteins, things like seafood, poultry, the dairy foods, and again, occasionally with the red meat. And that, for portion sizes, looking at the plate again, you can use, if you're kind of cutting it up as a circle, make the plate, 1/3 of that animal protein source as a, good way just to kind of manage without having to actually count and calculate every single meal that you're having. And you want to limit or avoid the foods that increase cancer risk. So again, this includes alcoholic drinks, ideally avoiding them altogether. But if you do have a drink, limiting it to 1 for women and 2 a day for men. Avoiding, if you can, the processed meats and limiting red meat to, no more than 3 times per week, as discussed, and less is even ideal. And including physical activity, 30 minutes a day, 5 days a week. So how do you actually go about doing these things? It's very easy to say, make these changes, but then when it comes down to actually doing them, it can be very daunting sometimes if this is just not something that's part of your everyday. So a lot of times creating goals and making small changes, as kind of a step-by-step process can be a way to approach it. So for example, if you want to increase the fruits and vegetables in your diet, what's your first step? Maybe it's to start is at each meal, eat at least 1 portion of fruits and vegetables. This is a goal that's very specific. It's realistic and achievable, and you kind of put it into a specific frame. So I know I'm having lunch, I'm going to have a portion of fruits and vegetables. And then as you are able to kind of achieve that, you can learn and grow. Maybe the next step is kind of pushing yourself a little bit and creating a challenge. So maybe it's following that plate guideline. I'm going to fill 1/3 or half of my plate with vegetables and pick a meal. Maybe it's lunch or dinner, or maybe it's lunch and dinner. You can kind of even make that a step-by-step approach. Maybe it's eating a certain number of pieces of fruit a day, or it's adding extra vegetables to soups and stews, any kind of meals that you have, even scrambled eggs, an omelet, it doesn't have to be a fancy omelet. You could just throw some cut up vegetables in there to help add to your vegetable intake for the day. Beans and legumes, same thing. What's the first step? Maybe it's eating 1 serving of beans a week and then expanding from there. Maybe it's a few times a week, 2, 3. Maybe on your meatless day, you're replacing some of the items with the tofu or the beans or the lentils. And then whole grains. Again, starting small, 1 serving of whole grains a day. And whole grains, just to clarify, are anything that's not very processed. So this doesn't include things like white bread or white pasta. This, if you ever read the label of a package, it's going to say, for example, say a slice of bread, the first ingredient should be 100% whole wheat. This is a good indication that it's a whole grain product. Things like brown rice, quinoa, even oatmeal, oats are good whole grain sources as well. So you can, start with 1 of those a day and then grow little by little as you increase. I will just have 1 caveat. If you're not really a big fiber eater, You definitely want to just start slow. You don't want all of a sudden want to incorporate a ton of fiber in your diet. Sometimes when you go too quickly, this can cause gas. So just starting slow and increasing little by little can improve your tolerance to it, so that you're not necessarily turned off to it initially in the beginning. Being physically active. I know a lot of us are stuck at home, with still working from home perhaps, or not going out as much with everything around COVID. So how do you incorporate physical activity into your life? We've talked about 30 minutes a day on average being a goal for 5 days a week. But that can be tough to start out at. So, maybe it's 15 minutes. Maybe it's 2 or 3 days a week to start. And then you grow and build from there and increase, by 5 and 10 minutes every week, and increase the number of days each week. Maybe you can use, if you have a Fitbit or even on your phone that counts steps, making a goal of up to 10,000 steps a day. And then what we're going to be reducing are, the high calorie foods and beverages. So if you're maybe a big soda drinker, or you really like fast foods, or, you're really into eating cakes every night at dinner, or, sweet treats at breakfast, take a look at what you're doing, and maybe it's reducing at least one of those foods throughout the day. If cutting out one soda out of however many you drink, and then build from there. If you're fast food, you can reduce it. You limit it to one no more than once a week. Replacing soda with water or zero-calorie beverage twice a week or twice a day, in place of some of the drinks that you're having. You kind of have to look at what your life is, and make something that's realistic that you'll actually be able to stick to. And then once you start making those small changes, over time you'll grow and you'll be able to really, kind of embody or embrace the recommendations as a whole that we've gone through today, and start making, big changes in your diet and seeing an impact on your overall health as well as your weight. So thank you very much for your time tonight.
Thank you so much, Marissa. That was great. Okay, I'm going to turn the program over to our last speaker for this evening, Dr. Julia Smith, who is a medical oncologist. Dr. Smith, can you hear me okay? I'm going to unmute you right now.
Yep, I can hear you.
Okay, perfect. And I'm going to turn the presenter rights over to you, and you can share your screen.
Is my screen being shared? How do you see that?
Let me see. You know what? I can bring it up on my end if that's easier. Let me see. Hang on one second. Okay, can you see that all right?
Yeah, I can see that. Now, can I advance these, or are you going to advance them?
I'll advance them. Just let me know when you're ready.
All right, I'm ready. I advance them.
Okay.
Okay, good. So now I'm going to talk to everyone about, I know you've had a very good symposium and you've gotten lots of information about colon cancer. And what I want to talk about is how to think about, can you hear me?
Yeah.
Rachel? Yeah. How to think about risk reduction and prevention, what to do so that you don't end up with colon cancer, or if you do end up with any cancer, you do everything you can possibly do and need to do to prevent getting another cancer. So that's where medical oncology has gone these days. We're very happy to say that we've moved from just trying to manage disastrous diagnoses of cancer when they come in to really helping people deal with the cancer, survive the cancer, and then in themselves and in their family prevent other cancers. So I want you to think about, on this first slide, how many people in the United States who have colon cancer have a family history, and look at those percentages and see what you think. We can go to the next slide, Rachel, and I'll give everybody the answer while they're thinking about it. Okay, about 25%, a quarter of people who have a family history alone. This is not a hereditary genetic syndrome, which we're going to get into, but a significant family history with no known genetic syndrome. That doesn't mean there isn't one, and it also doesn't mean there aren't other causes, because we don't know everything, and we are learning more and more about the underlying causes of cancer and colon cancer. So there could be a genetic basis that we haven't yet understood. There could be environmental. It could be a combination of both of these or other things as well. But we do know at this point that more than 10% of people who have a family history of colon cancer will turn out to actually have a well-known genetic syndrome. And that whole field of genetic syndromes and genetic understanding is exploding. We understood for a long time familial polyposis, that I'll talk to you about in a little while. And we understood for quite a while now the Lynch syndrome, but now we're learning about other syndromes that can have a significant impact on a person's lifetime risk of developing colon cancer. And it's very important for us to identify them, because then we can intervene and hope to totally change the course of developing cancer and a person's survival. Next slide, please, Rachel. Okay, so how can we out there think about what our risk is and what kinds of things contribute to an increased lifetime risk of colon cancer, so you can know what to talk to your doctor about, what to think about yourself, what kind of information to arm yourself with to make sure that you can prevent this from happening. So one is the family history and the genetics, and we're going to get into that. Another is any personal history that may be pertinent. There are associated medical diseases like gastrointestinal diseases, inflammatory bowel disease, ulcerative colitis, Crohn's disease. There are other exposure histories, environmental exposures that can be a problem and contribute to risk of colon cancer. And then you just heard much about this, but it's very important to think about your diet, your BMI, your not so much, yes, your body weight, but more the percentage of that body weight that is muscle and the percentage that's fat, and then alcohol, tobacco, and exercise. As I won't go into that because Marissa did a great job on that. Next. Okay, so what should make any one of us think about something in our family that suggests there could be a hereditary predisposition to cancer in general, And the kinds of things you're looking for are, lots of people get cancer, but there are certain sort of red flags that make us think that that wasn't just a coincidence or what we call a sporadic cancer, but there's actually something underlying in the family that may predispose people to a higher risk. So you're looking for things that don't just fit the usual random sporadic cancer pattern in the country. If somebody has a young age of diagnosis, that's unusual. And then you think to yourself, well, maybe that's because there's some underlying predisposition, and that could be a genetic predisposition. If there are certain unusual cancers or groupings of cancers in the family, certain cancers run together genetically. So if you see a family or you have your own family, when you look at the history and there's a combination of ovarian, if there's male breast cancer, pancreatic, melanoma, sarcoma, gastric, and brain cancer, these kinds of things can be tip-offs that there may be an underlying link genetically. multiple primary cancers in one individual. So, okay, it's bad luck, and it's not all that unusual, unfortunately, for someone to get cancer in our society. But it is unusual if someone gets more than one cancer. That is not the usual. And there we should be saying to ourselves, maybe that could be because they have an underlying predisposition to cancer. And these familial clusterings that we're talking about, and I'll go into more, like colon with endometrial in the family, breast with ovarian in the family, melanoma with pancreatic, those are suggestive of an underlying hereditary cause. And then this we've known for a long, long time, even since I was in medical school, which was a long time ago, many colorectal polyps in the same family or the same individual. That could mean that there's an underlying predisposition to colon cancer. And then certain kinds of familial hereditary groups, like people who know that they are at risk because that group, their ancestry has a higher risk. For instance, the Ashkenazi Jewish population for some mutations, or because you have a relative who says, oh, I have this mutation, then you have to think, could that be present with me too? Next slide, please, Rachel. Okay, here is the general population lifetime risk in the United States for colon cancer. For men, 1 in 23 men, 4.3% of men, 1 in 23 will get colon cancer. And for women, it's just a little lower, 4%, 1 in 25. And the key here to focus on is whether you have family members who have a diagnosis of colon cancer, because it doubles twofold higher if there's one family member that has been affected. And if there are 2 or more, it goes to at least 4-fold higher. Next slide, please. Now, these are, I was talking about the hereditary, the genetic predisposition that we know of, the syndromes. One that is well defined at this point is what's called Lynch syndrome, HNPCC. It stands for hereditary non-polyposis colorectal cancer. The mutations in these genes, there are 5 genes that constitute the Lynch syndrome, 5 genes. And certain mutations in any of those genes can give an increase and high lifetime risk of colon cancer, and for women, endometrial cancer. And then there are a whole list you can see on the bottom of that slide where it says other HNPCC associated cancers. There are a list of other cancers that can occur. The 2 most important are the first listed, gastric and ovarian, because each of those have in the range of a 10 to 13% lifetime risk. All of those cancers, colon, colorectal, endometrial, gastric, and ovarian, if you know someone has a predisposition to them, you can usually prevent that person from getting it. Next slide, please. Okay, now here are the polyposis syndromes. This is the one I was saying we've known about for a long, long time. FAP stands for familial adenomatous polyposis, and AFAP, attenuated familial adenomatous polyposis. This is where you go to the gastroenterologist, or a family member goes to the gastroenterologist and has a colonoscopy, and the gastroenterologist says they can't even count how many polyps are there. The whole lining of the colon is carpeted with polyps. That is likely to be a gene mutation. And those gene mutations in those APC genes confer a very high risk. If you have that hereditary cancer syndrome, a very high risk, essentially between 80 and 100% risk, lifetime risk of getting colorectal cancer if you have that. So that you must find out about and you must take care of so that you and your family don't get into trouble with that. There is another polyposis syndrome called MAP, or an MYH associated polyposis. That has sort of, the HNPCC or the Lynch don't have a lot of polyps. They can have only a few, but they can have those early onset, and they can have endometrial, that's uterine, and other cancers associated. And these polyposis syndromes have tons of polyps, and the MAP have somewhere in between. Can you give me the next slide, please, Rachel? Thank you. Okay, now here is a very important, especially for medical oncologists, this is a very important slide. It turns out that if somebody has a Lynch syndrome, a high risk of having colon cancer or an endometrial cancer or those others that I talked to you about, then, and they get diagnosed with one of those cancers, that person has a high chance of a second cancer. So if they have Lynch syndrome and they have a cancer, 50% will get another second cancer within 15 years. Now, this didn't matter that much before 1990 because we were just trying, to get people through their original diagnosis, and we didn't have cures for a lot of these cancers. But now we often expect to cure people of these cancers. So if you get one of these cancers and you're going to get cured, it becomes extremely important that if you're going to get another one within the next 10 or 15 years, we know how to protect you so that that doesn't happen. The risk of the second cancers with the familial adenomatous polyposis syndromes are much less. You can see those risks are down on the order of less than 10% and some less than 2%. But the only really important thing to know there with second cancers is that if you get diagnosed or it's in the family with a familial polyposis syndrome, be sure that anyone who's thinking about having children lets their obstetrician and pediatrician know, because there is an increased risk of hepatoblastoma, a kind of liver cancer in children under the age of 5. So for those children, for the first 5 years, they have to have their liver followed closely. Next slide, please. Okay, so what do we do if we want to think about counseling someone and deciding with them whether they should have risk assessment, risk reduction, screening? Well, first of all, they have to come in and see us, and then we have to talk about it so we can give them the information. Then we have to assess what their risk really is, as best we can. And then we have to talk about recommendations and options for prevention and screening, because everything has, risks and benefits, and it's a trade-off, and we have to do what fits in with that person's life, with their tolerance for risk, and what their risk really is. And that's why it's very important, this next point, to partner. The doctor and the patient have to partner all through their care with the risk reducing strategy decisions. And then we tailor it to the individual. And it's quite important to advise each person who comes in to be sure to try to share as much as they can in terms of their risk with their family so that their family can be protected too. Next slide, please. Okay, this is how we do the assessment of risk, the kinds of things we think about. One, you do a fairly extensive pedigree or family history, trying to understand who has had cancer in the family, how that person is related to, to our patient, the type of cancer they have had, the age at the diagnosis of cancer, whether they have had polyps, and if so, what kind of polyps have they had? Are they adenomatous polyps? Are they hyperplastic polyps? Where were they located? How many of them? And what age were those diagnosed? And a lot of that also involves trying to dig out stuff from, old medical records. Then, because of the things I was saying before, we need to get a good medical and surgical history. So we need to know whether our patient has any personal history of cancer, whether there's a previous colon history, including the polyps, the number, the type, and whether there are other medical conditions that could give us clues about whether there's a hereditary predisposition in the background, and then any carcinogen exposure. And then you do need a physical exam. That's important because of the things I was saying, to have a good GYN gynecologic exam for women, and often a skin dermatologic exam, usually a thyroid exam, and very importantly, I think the point's been made over and over today. Get your colonoscopy and scoping if you need it, and when it's appropriate, because it really does save lives. Next slide, please, Rachel. Okay, and then we think about whether it's appropriate to do what's called germline genetic testing. So what that means is that usually from any cell in the body, you know, when anyone is born, when you're forming in utero, you start as one cell, and then you start dividing until you become, you know, this for their organs, and then an actual human being. That means, you know, really an enormous number of divisions of the cell, but we all started from one cell. So every single cell in our body contains the same DNA, the same chromosomes that were there in that one cell in the beginning. So you take, you know, a few cells, and you can either get that from, often it's done from a tube of blood or two. Sometimes you can just get it by scraping off some cells from the inside of the cheek. So saliva spit test can do it. But you have to get a few cells, enough cells that the lab can extract the DNA and analyze the genes. And then from that DNA, you can think about what you want to look at, what kind of genes you want to look at. That decision about, you know, whether to do the genetic testing and what kind of testing to do, that is something we have to talk to each patient about and think about in terms of what their own personal and family history is, and what is their probability of carrying a mutation, which kinds of things are we looking for, how does the person feel about getting those kinds of results, what kind of results will they be comfortable with, uncomfortable with, will, you know, how much do they want to know? Do they want to know everything we know, we can possibly know, even if we don't have absolute guidelines about how to follow it, so they can be followed in the future and know what could be coming? Or do they feel like they just want to know something very specific? And then there are a few possible results of this genetic testing and looking at these genes. You can have what's called a true positive result. That means that you have a mutation in a gene that is known to confer an increased lifetime risk of cancer. And then from that, we decide how to handle it and what kinds of prevention and screening we should be thinking about. You can also have a result that's what's called a true negative. That's a great result. That means that you have a family member who has cancer, so you're worried that you might have an increased risk. That family member gets tested for their genetics, and they have a mutation that explains why they got cancer. But then we test you, and you don't have that mutation. That means that you did not inherit that gene or that gene mutation from that side of the family, and you are a true negative. You do not have the risk of that cancer increased from your family history. Also, you can get a result that is what's called indeterminate. And that just means that you look at that family member who has cancer, you do the gene testing, and they're negative. Then we have to say, well, and you're negative too. Then we have to say, well, okay, that's good because you don't have a known mutation. On the other hand, since the family member who has the cancer doesn't have a mutation, it is possible that that family member actually has some gene we haven't discovered yet. Remember, I said we really don't know everything, and we are uncovering new genes and new understanding all the time. So if you don't know whether somebody in your family has a gene mutation because their test is negative, and we're thinking maybe they have something that we don't know about, we haven't identified yet, then you look at what the family history is, and we talk together about whether we want to do additional screening in case. And then the last possibility is what's called a MUS or a VUS. that is inconclusive. Sometimes the lab will come back with a mutation in a gene that the lab classifies as what's called a variant or a mutation of uncertain significance. That just means, these are enormous genes, and there are thousands and thousands of mutations. And all that means, if they get a variant of uncertain significance, is that the lab just doesn't have enough data yet to tell us whether that mutation has any risk or not. The vast majority of mutations of uncertain significance turn out to be nothing. But in that case, it's important to have someone who understands how to follow that mutation and keeps you apprised of what's going on as data evolves with that mutation. Then you make a decision together whether it's appropriate and you want to have genetic testing, and that has to be based on the risks and the benefits, the assessment of how high the risks are, and also we have to make sure we get it covered by insurance because it can be a very expensive test. That used to be a huge problem, especially when genetic testing first came out in the late 90s. It's gotten much more under control, and it's rare now that we can't find a way to get somebody almost, if not entirely, almost entirely covered. Okay, next slide, please. Here, if you find out that you or a family member has hereditary non-polyposis colorectal cancer syndrome, or Lynch, this is what the guidelines are for following that person. And it's extremely important because of what I said, that there are those high chance of the second cancer in addition to the first cancer. High chance of the first cancer, even with the cancer, high chance of a second cancer. Incredibly important to stick to these guidelines, because the Lynch polyps, the colon polyps that form because of the gene mutation with Lynch, they behave differently than those sporadic polyps that everybody gets who doesn't have this kind of syndrome. They divide much more quickly, and so you must get them out before they become cancer. And so the guidelines are that starting at the age of 20 to 25, everyone with Lynch syndrome needs a colonoscopy every 1 to 2 years, and shouldn't go past 2 years. And then after the age of 40, the colonoscopy should be every year. Because of what I said about the risk of endometrial, uterine, and ovarian cancer, the women should also have close follow-up by their gynecology. So endometrial, uterine aspiration, transvaginal ultrasounds, and a CA-125, which is a blood test starting at the age of 25 to 35, depending on the family history, every 1 to 2 years. Now, especially with one of the genes, but it's something you have to think about with any of the Lynch genes, but especially with the MSH2 gene, and especially if there's a family history, because of what I showed you before on that slide, where there can be GU, genital urinary, urothelial bladder cancers and renal cancers, that it may make sense to consider screening with annual urine cytology, looking at cells in the urine, and regular analysis starting at the age of 30, and screening for the other Lynch-associated cancers, the duodenum, the small bowel, biliary, pancreatic, brain, and breast. That's done on an individual basis with your doctor deciding what your risk likely is. Next slide, please. Okay, and here you can see if you have one of those familial polyposis, adenomatous polyposis syndromes that I said, it's essentially a foregone conclusion that that person will get colon cancer if you don't do something to protect them. Those people with familial adenomatous polyposis have to start screening with the sigmoidoscopy at the age of 10 to 12 years old, because there's a predilection for the rectum, and then a colonoscopy every 1 to 3 years, beginning in the late teens and early 20s, and an upper endoscopy should be done as well at that time. Can I have the next slide, please? Okay, now how to manage your risk. Well, there is surgical intervention and surgical prevention. So what's called a colectomy, a total colectomy, where you remove the colon. And that is something that we do when there's a very, very high risk. And people can adjust and live a fine life without their colon. There's the enhanced surveillance that I just talked about. And then we're looking very hard for some kind of agents that will drop people's risk of colon cancer, colorectal cancer. And there's some evidence, but this is really still very preliminary, that maybe aspirin or NSAIDs, that's like ibuprofen, or oral contraceptives may decrease the risk. Next slide, please. You heard about this, but it's extremely important. So I just want to emphasize it again. It really matters. It really matters what lifestyle modifiers in terms of developing cancer. So cigarettes, no, forget about them. Weight control is very important with a healthy BMI, body mass index, a healthy diet that you heard described, regular exercise at least 3 times a week, minimum 30 minutes each time, and more is better. And the less alcohol, the better. Okay, next slide, please. So I want to just remind you all to just think about these things. You can do a lot now. The field has burst open, and you can do a lot to protect yourself, to protect your family, and to take care of yourself if anything happens. So plan, be sure to go into your doctor with any questions you have, and bring some close person, someone close to you with you, so that they can help you think of things to discuss. Work together with your doctor. It has to be a team approach. And remember, it is never too late. If you're doing any of those things that we talked about that we rather you don't do, it's okay. Just slowly start to change that and move towards a healthier lifestyle. And remember, even if you have no family history at all, get your colonoscopy. We only have a few screening tests for cancer that are as good as this. And this really makes a difference. It can prevent colon cancer altogether. And it does prevent colon cancer altogether. And even if you have a colon cancer, you can find it when you can absolutely intervene and change survival. Next slide. I'm trying to hurry because I know you guys are hanging around late. I think that's the last one. So
that's
what I want to say. Thank you very much.
Thank you, Dr. Smith. That was great. Okay, it's after 7:30. I see we have a couple questions here that I'm just going to go through. We have one for Marissa here. Can we visit with the nutritionist without a reference from the primary?
So, well, my role specifically, I work at the cancer center, and I can see any patient that has a doctor at the cancer center. Overall, within NYU, there are other dietitians that are available. So you would likely have to go through your primary care doc to try to find someone that you'd be able to meet with.
Okay, thanks, Marissa. And it looks like that was the only question here. So with that being said, thank you to all of our speakers. Thank you for all the great information you presented tonight. And thank you to everyone for tuning in. We will see you next time.